Hello, everyone. We are going to discuss anemia this week. So, we are going to discuss the components of the blood and their function. When we talk about the components, erythrocytes are essential for O2 transport within the circulatory system. They contain hemoglobin, which moves O2 from the lungs to our tissues. They carry O2 to the tissues and then remove CO2. And so when we look at the different types of components, we have our erythrocytes, and then we have our platelets, which are thrombocytes, and these are coagulation factors in the plasma, and these are essential for the blood clotting process. We also have our leukocytes, which are our white blood cells, and this helps with that inflammatory and immuno response. We have different types of leukocytes, like our neutrophils, and this is going to be the most abundant type of leukocytes. These are going to be our early responders to those bacterial infections. We also have eosinophils, which are a type of disease-fighting white blood cells. These conditions most often indicate a parasitic type of infection. The basophils are associated with inflammatory reactions, particularly those that cause allergic symptoms. So these are involved in our immune and inflammatory responses. These are increased in a response in allergic or even asthma attacks. And then we have our monocytes, which are a type of white blood cells that kind of help fight bacteria, viruses, and other infections within the body. And then we have our lymphocytes. We have our T lymphocytes, which produces T cells, our B lymphocytes, and then our natural killers. Our B lymphocytes actually produces antibodies, and then the natural killers are going to be those destroyers of viruses or cancer cells without needing any antibiotics. When we talk about transport oxygen, we see that erythrocytes, our RBCs, is important to the O2 transport in our body, and that actually contains hemoglobin, which moves O2 from our lungs to our oxygen, and they carry O2 to the tissues and remove CO2. To note for tests, do know that erythrocytes are those red blood cells, so low blood oxygen can indicate low erythrocytes. And then the cellular components of your basophils, which looks at asthma attacks and inflammation. Again, when we talk about erythrocytes, these are going to be essential for that O2 transport within the circulatory system. They contain hemoglobin, which moves that O2 from the lungs to our tissues, and they carry O2 to the tissues and remove CO2. So when we look at the production, we see that red blood cells has bone marrow, erythropoietin, and this requires iron, vitamin B12, and folate. The purpose is for that gas transport, so that O2 to CO2 acid base balance, and then the hemoglobin carries oxygen. So erythrocytes again are essential to that O2 transport within the circulatory system, and they can contain hemoglobins, which moves O2 from the lungs to our tissues, and they carry O2 to the tissues and remove. So erythropoietin, which is EPO, is released from the kidneys in a small amount from the liver. So when oxygen levels in the blood are low, EPO does stimulate the bone marrow to produce red blood cells, and in the marrow, the stem cells mature into immature RBCs. These immature RBCs are also called reticulocytes, and they are released in the bloodstream. So when we look at reticulocytes, these mature into fully functioning RBCs, and the liver plays a supporting role by regulating iron storage and metabolism, which is crucial for RBCs production. Iron is used for the hemoglobin in RBCs, which is necessary to carry oxygen. Vitamin B12 and folate are essential for DNA synthesis in the bone marrow, which allows proper cell division and maturation of RBCs. So, mature RBCs carry oxygen throughout the body and live for about 120 days. Again, when we talk about iron and the production, we see liver playing that supportive role, and it really regulates that iron storage and metabolism. And this is going to be crucial for that RBC production. And iron is used to form that hemoglobin in RBCs, which is necessary for carrying. When we look at vitamin B12 and folate, this is going to be essential for that DNA synthesis in the bone marrow, and this allows for that proper cell division and maturation of the RBCs. The purpose of the red blood cells is going to be to transport gas like O2 and CO2, as well as to make sure we have that acid base balance. And then hemoglobin carries oxygen. And so these pictures are showing the lungs and how we inhale the oxygen, and then we make the carbon dioxide and water, and then all of these turns into bicarbonate and are excreted through our kidneys. So what is anemia? Um, we are going to take a moment and just discuss what anemia is, what does it look like with the patient, and how does the body react, and what should the nurses do. And so I will have a handout for you guys to do that, and then we will discuss it. When you are looking at this handout, I want you to think about what will the patient look like, what assessment questions should you be asking, what will the patient describe as far as what they are feeling, how are you going to document these signs and symptoms, what labs are you going to be anticipating, and then how the condition is similar from different versions, and then what does a mild version of anemia versus another like more severe, and what does the more advanced. Older adults are more likely to show signs and symptoms of anemia when those moderate levels of hemoglobin are affected. So under the so what portion of the 3 column notes, I do want you guys to write down pathos and clinical manifestations and even compensatory mechanisms. And then under now what, you can write down what the patient will look like, what labs will be anticipated, and how they will be documented. Um, there are more sufficient circulatory hemoglobin masses to meet the metabolic need in the body, and feedback mechanisms ensures that when the amount of oxygen reaches the tissues decreases. So compensatory increases occurs in the production of red blood cells. The feedback mechanism regulates RBC production is under control of a erythropoietin. So, anemia can cause pallor because the reduced hemoglobin levels lead to a decreased oxygen carrying capacity, and these levels, this less red coloration in the skin and those mucous membranes. And so, what's happening is not enough red blood cells, and they are functioning poorly. So, when we talk about clinical manifestation, the heart is overworks to compensate for those low level of oxygens in anemia by pumping faster and harder, which can strain the heart and lead to chest pain, especially if they have underlying heart disease. So, what does this look like for a patient who has anemia? So, when we talk about blood carrying less oxygen, we're going to see fatigue, weakness, pallor. So, that's just going to be that pale skin, lips, and gums, and then activity intolerance. And how does the body react? Well, the body tries to increase oxygen in the blood. So, you may see individuals hyperventilate or even increased heart rate. And it tries to decrease the demand of oxygen and forces rest through fatigue. When we talk about mild anemia, we usually is associated with no clinical symptoms. Healthy young patient may present with very few symptoms if we see a hemoglobin level of 7 to 8. Elderly patients with cardiovascular or pulmonary disease may have symptoms even with the modest degree of anemia. So, when we look at the classifications of anemia, we have different types. We have iron deficiency, precaneus, which is going to be vitamin B12 deficiency, megaloblastic, which is folate deficiency, aplastic, hemolytic, sickle cell, and polycythemia vera. And so, these are all the different types of classifications. of anemia. So we'll talk about iron deficiency anemia, which is going to be the most common nutritional deficiency in the world. The most common cause of anemia. So most common cause in men is GI bleeding, and in women is going to be menorrhagia. 70% of iron is in the red blood cells. So blood lacks adequate healthy RBCs that is needed to carry to the O2 to the tissue. So without enough iron, your body can't produce enough RBCs, and that we need that to allow them to carry the O2. Patients become um, fatigued. And when we talk about microcytic, these are going to be very small RBCs. There's four main reasons. So blood loss, lack of iron in the diet, a reason iron cannot be absorbed, and pregnancy. When we look at hemodialysis, this can actually lead to iron deficiency anemia through several mechanisms. So blood loss during dialysis. So those small amounts of blood are lost during each dialysis session, especially from blood retained in the dialyzer or the tubing, which accumulates kind of over time. We also see an increased iron amount. So erythropoiesis stimulating agents like ESAs, often used in dialysis, treats patients for anemia. And this stimulates red blood cell production, which increases the body's iron needs. Hemodialysis can cause iron deficiency anemia due to blood loss during dialysis. So we want to frequently test their blood and reduce those iron absorptions or that increased iron demand. Pica, for whatever unknown reason, we don't really know what causes pica or why individuals will have pica. Um, but we see that that is also a cause for anemia. Um, we also see blue sclera, which happens due to the thinness and transparency of collagen fibers of the sclera, and this allows a visualization of the underlying pigmented layer of the eye. This happens with iron deficiency anemia. We also see that possibly due to blood flow and weakening underlying the nails connective tissue. So we may see discoloration in the nails as well. How we are able to diagnose iron deficiency anemia is by low serum ferritin. We will see a CPC. Platelets may be normal, but we may see that low serum ferritin levels as well as low iron levels, and we may see an increase in that total iron binding capacity, TIBC, and this looks at and measures the blood's capacity to bind to iron with transferrin. So the liver produces more transferrin to capture more iron. Let's see, increases. So clinical manifestations, we talked about pica, spoon-shaped nails, and this is due to the um, poor blood supplies and weakening of the nail connective tissue. We also see angular erosion of the corners of the mouth. And then with anemia, some of the other clinical manifestations may be dyspnea, weakness and fatigue, palpitations, and tachycardia. When we talk about vitamin B12 or precuneous or folate megaloblastic anemia, values are not as low as seen in the aplastic anemia. So folate deficiency causes by alcoholism. So we see liver cirrhosis and then malabsorption. So disruption in the DNA synthesis of blast cells produce megaloblasts, so very large abnormal bone marrow cells. The RBCs are larger than normal, so they're going to be macrocytic or megaloblastic. The purpose of the Schilling's test is to determine how well the patient is actually absorbing vitamin B12 from their intestinal tract. It's named for Robert F. Schilling. So your body uses vitamin B12 to make RBCs. Anemia is a condition in which your body doesn't have enough healthy RBCs to transport oxygen to your organs and tissues. So it is done in 4 stages over a short period of a few days, and measurements are obtained in your urine specimen. So when we look at the pathogenesis of the precutaneous anemia, and then folate deficiency, and then why these are not all coming up. Vitamin B12 is necessary for the production. We need vitamin B12 in our diet, and so milk, eggs, red meat, fish, poultry. So without this, we do not get the O2 we need and can feel weak and tired. Vitamin B12 is absorbed by intrinsic factors located in the lining of the stomach. B12 deficiency can lead to peripheral nerve degeneration. Gastric analysis reveals how hydrochloric acid in the gastric section are absent or low. When we look at megaloblastic madness, this describes the clinical features of vitamin B12 deficiency. So paranoid ideations, dementia, cognitive dysfunction, delusions, and hallucination. Folate deficiency is significant risk for neural tube defects, particularly spina bifida and encephaly. Folate and B vitamin is crucial for cell division and growth, and its deficiency actually can disrupt the proper closure of the neural tubes during early fetal development. When we talk about oral B12, this can actually help in precutaneous anemia, but high doses usually are needed. So because absorption is poor due to lack of intrinsic factors, even without intrinsic factors, a small amount can be absorbed through passive diffusion in the gut. However, intramuscular injections are often preferred initially for faster correction. So injecting vitamin B12 IM allows to be absorbed directly from the muscle into the bloodstream, bypassing the digestive system. So the Schilling's test is going to be where we inject that non-radioactive vitamin B12, and then we collect those samples. The other diagnostic testing is going to be the gastric analysis. So this evaluates stomach acid production, measurement amount of acidity, and gastric secretions in precutaneous anemia. This often shows lower absent hydrochloric. Um, Again, these are different ways to test. Paresthesia, so tingling, burning, numbness sensation also can be indicative of vitamin B12 deficiencies. Your body uses vitamin B12 to make RBCs. Anemia is that condition in which your body doesn't have enough of those. When we talk about clinical manifestations, we will see pancytopenia, which is going to be low RBCs, white blood counts, and platelet counts. And we may see an increased megaloblastic dysplasia. So MCV is going to measure the average size of the red blood cells. B12 and folate deficiencies actually disrupts that DNA synthesis, and this is going to lead to fewer but larger RBCs, which causes the MVC to increase. Peripheral nerve degeneration is also seen. So we see the demyelination of nerves because of that toxic buildup, and that impairs the myelin synthesis. This is going to be why we see paresthesia, which is that tingling, burning, numbness sensation, and weakness. In megaloblastic madness, this is going to be very severe vitamin B12 deficiency, and we see neurological and psychiatric symptoms due to that demyelination of nerves, especially in the spinal cord and the brain. So we'll see delusions, hallucinations, depression, irritability, sleep deprivation, as well as cognitive dysfunction like dementia and memory impairment. When we look at aplastic anemia, plastic means to make. Aplastic is not enough blood cells being made. So we see that it's characterized by the decrease in RBCs and often seen in chemo patients. So this decreased bone marrow production of red blood cells. This depressed bone marrow production actually decreases the mature blood cells and is why we see anemia. So we see decreased platelets, which is also known as thrombocytopenia, decreased leukocytes or WBCs, leukopenia, and all three decreased low RBCs, WBCs, and platelets equals pantocytopenia. Bone marrow biopsies is a definitive diagnosis for aplastic anemia, and we will still look at patient's exam, history, and labs. So the most common form of aplastic anemia is itogenic, which is resulting from marrow failure after treatment with chemo and radiation causing bone marrow damage. When we talk about clinical manifestations, we do know that stem cell disorder can be classified. Um, we are going to put these individuals on neutropenic precautions because of the risk for infection and then risk for bleeding, so like gum bleeding. So we want to use soft toothbrushes. We usually, again, these are caused by toxics, and so we want to make sure it can be fatal if not successfully managed. So insidious is going to be a clinical manifestation, transient murmurs, which are innocent heart murmurs that blood flows more quickly than normal through the heart. This can be seen when not enough RBCs are present to carry O2 to the tissue. Again, we are going to look at the diagnostic testing, the bone marrow clinical manifestations, anemia manifestation, weakness, fatigue, lethargy, dyspnea, pallor, palpitations, tachycardia. When we talk about bacterial or viral infections, neutropenia, we see fever and chills, risk for bleeding, and so hemolytic or thalassemia. This is going to be hemolytic hemolytic anemia. The synthesis has a defect and it's resulting in a mutant gene. So something has altered the DNA makeup from parent to child. So knowing family history is important. When we look at the erythroblastic hyperplasia, this lab test actually results in indicated abnormal. So when we look at the pathogenesis, this is going to be an increased RBC's destruction, resulting in a decreased RBC survival rate. There's two different types. Each affect the production differently. You have your alpha and your beta. And when we although this is a rare disorder, a rare anemia, um, it can it isn't inherited. So lower hemoglobin RBCs in the body, hemoglobin in the RBCs, again, we see that there are two different types of manifestations. Both can cause imbalanced production of hemoglobin, leading to a premature destruction. Testing for this is going to be CBCs, bone marrow, and then low neutrophils. We'll see splenomegalia, which is the spleen is overworked to break down and remove excessive abnormal RBCs. Hepatomegalia, which is the overwork to help produce RBCs. Jaundice is going to be that abnormal RBCs breakdown, which releases bilirubin. Leg ulcers because of that poor O2 and poor blood flow to the tissue. Bone deformities, Mongolian face. And so here are some of pictures. Let's see. Delayed development. So chronic anemia really reduces that O2 to the tissues and the organs. So this affects the growth and the cognitive development. And symptoms in general. We see sickle cells, so a defect of hemoglobin synthesis results in hemoglobin instability and insolubility. A sickle cell crisis is a painful episode that begins suddenly in a person who has sickle cell disease. So sickle cell crisis occurs when sickle cells shaped red blood cells clump together and block small blood vessels that carry blood to certain organs, muscles, and bones. This can happen in any part of the body, but the patient will need O2 fluids and pain medication for severe pain caused by sickling effect. There is a mutation in the gene that helps your body to make the red iron rich component that gives blood its color. In sickle cell anemia, the abnormal hemoglobin causes RBCs to become more rigid, sticky, and misshapen, and it is passed on inherently. Male and female must pass on defect. If only one parent has it, the child will make both abnormal and normal hemoglobin, meaning blood, some sickled cells, and presents with no symptoms. When we talk about clinical manifestations and things that can happen as a result of sickling, we see stroke, pulmonary hypertension, anemia, painful swelling in the hands and feet, delayed growth, visual abnormality, and pain. Because RBCs is shortened by the sickling and may precipitate a hemolytic crisis with jaundice because of the accelerated breakdown of RBCs, causing an increase in bilirubin, the breakdown of hemoglobin leading to jaundice. We see this almost exclusively in African Americans. There are different diagnostic testing like RBCs as well as blood smears. Sickle cell causes recurrent painful episodes because the abnormal crescent shape, because it makes it more rigid. So again, we see that jaundice because it's abnormal and it's breaking down. There are chronic hemolysis and vasal occlusions. Vasal occlusions is going to be that blocking of blood flow. This is going to be recurrent. It can cause embolisms, leg ulcers, stroke, organs, tachycardia because that low O2 makes the heart have to try to compensate, jaundice because that release of that bilirubin, excessive bilirubin, risk for infection. Chest syndrome is very serious. So chest syndrome is a serious complication of sickle cell disease characterized by new lung infiltrates. On a chest x-ray, it's accompanied by symptoms such as chest pain, fever, cough, difficulty breathing, and low oxygen levels, often caused by infection, fat embolism, or blocked blood vessels from sickle cell. The sickle cell anemia fat embolism can occur during a sickle cell crisis because the abnormal cells have sickled and it blocks the blood flow to the bone marrow, which causes the tissue to die. This releases fat particles into the blood that can travel to the lungs and block small blood vessels, contributing to chest syndrome. Priapism is a prolonged, often painful erection of the penis that lasts for more than 4 hours and occurs without sexual arousal. And this is usually due to the trapped blood in the erectile tissue. Sickle cell anemia causes this because of the abnormal shaped sickle cell. Red blood cells obstructed the venous outflow from the penis and leads to prolonged painful erection. Sickle cell is painful episodes that may begin suddenly in a person who has sickle cell disease. A sickle cell crisis occurs when sickle-shaped red blood cells clumps together and blocks small blood vessels that carry blood to certain organs, muscles, and bones. This can happen in any part of the body. The patient will need O2 fluid and pain medication for the severe pain caused by the sickling. There is a mutation in the gene that tells your body to make the red iron rich compound that gives blood its color. So sickle cell has an abnormal hemoglobin, causes RBCs to become more rigid. We talked about the lifespan is shortened by sickling and may precipitate a hemolytic crisis, which can cause jaundice because of that accelerated breakdown. This is looking at the sickle cell. So again, crisis, major medical event. It causes dehydration, infection, and cold, especially or cold weather. Polycythemia vera, so not anemia, just too many red blood cells. So an increased RBC mass means the total volume of red blood cells in the bloodstream is higher than normal. So this diagnosis is an increase in RBC. So this increased number of RBCs causes the increase in blood viscosity, and we also see an increase in the WBCs and platelets as well. So gout, kidney stones are associated with polycythemia vera, which occurs due to high turnover of red blood cells, which results in a higher than usual uric acid production. As the cells break down, more uric acid is produced. When we talk about PV, it is one group of blood cancers called myeloproliferative neoplasm, and there is a mutation in the gene of blood cell production. Our bodies normally regulates the number of RBCs, WBCs, and platelets in the bone marrow, but with PV, bone marrow makes too many of the blood cells. So without treatment, the patient can have blood clots. There is no cure. Treatment includes removing it by way of phlebotomy, antiplatelet medications, or diluting with fluids. When we talk about diagnostic tests, there's an absolute increase in RBC mass, hemostatic, and leukocytosis and thrombocytosis. So this is too much red blood cells, and blood is thicker. Common manifestations are going to be high blood pressure because of that high blood viscosity. Hypertension because of that increased red blood cell mass thickens the blood viscosity. When we talk about thrombosis, this is going to increase your red blood cells, your white blood cells, platelets, and clotting. Intermittent claudation, peptic ulcers, again, when we talk about polycythemia vera, this causes thrombosis because of the excessive production of red blood cells, and platelets leads to increased blood viscosity. In certain conditions like PV, the liver can become overworked when it starts to help produce red blood cells in a process called extramedullary hemopoiesis. This doesn't usually happen in healthy people because red blood cells production is mainly handled by the bone marrow. But if the bone marrow is overactive, damaged, or unable to keep up, then disease like PV, where the excessive cell production, the body may result in liver and spleen to help out, which stresses the liver and contributes to hepatomegaly, which is the enlargement of your liver. So pushing thick blood in PV is like pushing D5 through an IV. It's thick, sticky, and requires more pressure to move through the tubing. Just like how it takes more force to push D5 compared to normal saline, the heart has to work harder to pump the thickened blood caused because of the increased amount of red blood cells. So this increased efforts actually leads to higher pressures in blood vessels, just like increased pressures in the syringe. So PV is myeloproliferative disease disorder, characterized by that overproduction. And then it can lead to the hyperviscosity of impaired blood flow through small vessels, which includes the capillaries, which leads to congestion and eventually rupturing these fragile blood vessels. This combination of high red blood cell mass, abnormal platelets, and sluggish blood flow actually predispose individuals with PV to mucosal bleeding, such as nosebleeds, gum bleeding, and GI hemorrhaging. So think of your blood vessels like little tiny straws. In PV, the blood gets too thick like a milkshake instead of water. This thick blood moves slowly and it builds up pressure inside of the straw, especially in soft areas like your nose or gums. So if your pressure gets too high, the straw can pop and cause bleeding. That's why people with PV can get nosebleeds and gum bleeds. A red face or a ruddy complexion happens because these tiny blood vessels are full and swollen from the thick blood, but they haven't popped. So it's a sign of congestion, not bleeding. PV can cause intermittent claudation due to that increased blood velocity, and this impairs the blood flow to the extremities. So this leads to ischemia and pain during physical exercise. When we talk about PV, this is characterized by that overproduction of those white blood cells. So in PV, the increased red blood cells mass and blood viscosity leads to that sluggish flow. And we see peptic ulcers and changes in that impaired stomach blood supply, gastric mucosa ischemia, and weakened protective barriers. PV causes hyperuricemic and gout because of the increased turnover, which leads to the elevated serum acid levels. Other clinical manifestations we may see is going to be headache, backache, weakness, dizziness, weight loss, dyspnea, and joint complaints. Major complications is that increased blood viscosity and risk for thrombi. Without treatment, the patient can have blood clots. There is no cure, so treatment includes removing it by way of phlebotomy, antiplatelet medication, and diluting it with fluid. Intermittent claudation is that muscle pain or cramping in the leg that occurs during physical exercising, such as walking, and it's relieved by rest. Ruddy or florid face are going to be sinus vessels. Again, there's no cure, so without treatment, patient can have a blood clot. So the goal is to remove some of the blood with antiplatelets or by phlebotomy or diluting fluids. Thank you all. And here's the reference. Have a good one.